Hi everyone, Dr. K and Dr. H here. We are going to talk about the trail guide number 3 for the shoulder today. We're going to do the springboard ledge. We already went over the scapula and the back, and then we went over the trenches, the trail guide of the trenches. So today we're going to focus a little bit more on the bony landmarks and some of the joints that are within the shoulder as well. So we talked about finding the spine of the scapula, so you're going to go back to finding the spine of the scapula with those nice soft fingers. Remember, no whites of your fingers should show. We're going to roll all the way from that spine of the scapula to that first bony prominence. And Dr. K has lovely bony prominences for you to see. So we're going to look at those bony prominences, and we're going to know that that's the acromion process. This is a nice point of reference for us, especially in posture. So when we ask our patient to really get into nice posture, we're going to expect that acromion process to line up with the earlobe. If you find that acromion process, you're going to ride on it a little bit. Let's just test out a little bit of motion. Let's see what that acromion process moves through if you go into shoulder elevation, if you go into horizontal adduction, horizontal abduction. You should start to feel that that moves. I mean, we would expect that, right? Because the scapula should move with all of our arm movements. If you drop down off of that acromion process, as we come in to now find the other bone that comes in to connect to make that house for your shoulder, that clavicle sits there. You can see Dr. K has nice clavicles for us to see. You're going to feel along that. We're going to start at the sternum. We can move our way along. You can go onto that superior ledge. You can go onto that inferior ledge of the acromion. Or the clavicle, sorry. We know that it's an S-shaped bone. So we can see beautifully on Dr. K how when we're closer to the sternum or more medial, that bone is more prominent. So it actually comes away from the body wall a little bit more. As we move along, coming more superiorly and also laterally towards the outside of the shoulder, we'll see that that bone starts to dip in. So we kind of have a hill and we have a valley. Why don't you run your fingers along that and find the ridges? Most people, you'll find that there's more soft tissue on the underneath side of that than on the top of the clavicle. If we run along that, we know we found the AC, the acromion before, so now we're going to find the acromion clavicular joint. So we follow that acromion all the way to the tip of we follow the clavicle all the way to the tip of the acromion. At that point, we should start to feel there should be a little bit of space in that area. If we're not quite sure if we're on it, we're going to just ask for movement, right? Because we know that one of the special tests that we're going to do later on for the shoulder to test for AC joint dysfunction is the crossover test. So we would ask our patient to horizontally abduct and adduct. So we're going through horizontal abduction to adduction. A lot of times you'll get kind of that sharp pain if someone has an AC joint issue as they come across into horizontal adduction, and you should feel that movement in that. Let's also go through that shoulder elevation just to feel what happens at that joint. And what I want you to also notice is that clavicle goes through a lot of degrees of freedom as you ask your patient to go through those motions. Now let's move more medially along the clavicle, and we'll go more towards the sternoclavicular joint. So we have the sternum, which we know is this nice flat bone in the front, connects with the clavicle. We can see here that there should be 2 notches, and right in there is actually a little bit of a bursa or a disc that sits in there, and that disc can sometimes get a little bit impingement, especially with weightlifters, so that might be something to look out for. But really, this area of the body is rarely the cause of pain and discomfort for your patient. It's more stable just based on how the joint actually presents itself. So you're going to do the same thing. I'm just going to come around this so that you guys can see. I'm on that sternoclavicular joint. Same thing, you're going to go through elevation. You should feel that there should be movement underneath your hands. So I feel a little bit of gapping and a little bit of closing down. A little bit of gapping, a little bit of closing down. You can also go into that kind of horizontal adduction, horizontal adduction, just to see what happens at that joint. And you should see again that clavicle is moving with all of your arm movements. Just like your shoulder blade needs to move with all of your arm movements to clear those structures that come along with that. So we slid kind of more immediately onto the body. We're going to go back out lateral because we know that that scapula bone has those kind of hooks in it, right? So we're going to drop down. We found the acromion, we found the clavicle. You're going to come over. You can either come from the side. I'm going to actually come from the back just so that you can see it. If I find the clavicle, I'm going to drop a little bit into there. And right underneath that middle finger of mine, I'm going to feel the coracoid. What do we know attaches into the coracoid, right? We know that the short head of the biceps actually comes up and attaches into there. So what would be the movement for us to test? It should be resisted flexion of the arm. So we're really trying to get contraction of the biceps. And underneath your fingertips, you should feel that tendon pop underneath of your hands as you're doing it. Okay, good. So now we're going to slide and we're going to look at the deltoid. So the deltoid comes down into that nice triangle. As you come down into that deltoid, as they come down and insert onto the humerus, you're going to feel right in the mid shaft of the humeral bone should be your deltoid tubercle. This can also be a source of contention. So a lot of our patients that have shoulder problems, especially post-surgical patients, are placed into internal rotation for that protection phase. But what ends up happening is they tend to get a lot of pain down into there. So you're going to want to always check what those fascial restrictions are that ride through that deltoid and come down into that tubercle at that point. Okay, good. That summarizes our springboard ledge, so make sure you go through with your partner. Let's try it on a lot of different people to make sure that you can palpate lots of different bodies to feel it out. Great.